Hi, I wanted to do a quick introduction to the upcoming lower extremity module labs that I'll be running for you this summer. um, I feel like it would, when I was preparing this, I had a framework in mind, and I wanted to share that. This may be something you're already very familiar with. I couldn't find any evidence of it, however. So I thought I would go over this framework with you, and the slides are here, and pretty soon this video will be here as well. So other than the optional, watching this video is optional essentially. But beyond that, we have 3 labs. One will be on hip examinations and interventions. Another one will be on knee examinations and interventions. And the third one will be on ankle and foot examinations and interventions. A third of you will take all of them, a third of you will take 2 of them, and a third of you won't have to take any of them. However, I'm currently planning on being available in the labs at other times that I'll make known to you, that if you wanted to come in and review any of these, review or learn, some of these activities may be new. I couldn't find any evidence that some of them had been done, although I do have I have reasons to include them, that maybe some of them may come across as we go through. So every one of the lab sessions has what I'm calling an examination model, and which describes the pathoanatomical possibilities. This is not a complete set of all possibilities, clearly, but it is. There are enough of the possibilities that it's sort of a good starting point. I don't expect that you would have memorized everything on in these models. So if we open up one of these models here, what we see is a whole bunch of possible things that could go wrong with the hip, and different tests that help rule in or rule out the pathoanatomy of these conditions. So let me start now with the general framework. So there's a general framework that you'll be introduced to for PCM5 as well. It's just, I find it to be a helpful way to approach the examination process and the intervention process. So the evaluation is the bridge between the examination and the intervention. In many ways, what you're being educated to do as a physical therapist is to evaluate. And if you don't organize your examination based on the evaluation, then you're going to be examining every possibility, and that's not feasible. And if you don't organize your intervention based on the evaluation, then you're not doing anything that someone couldn't just do on their own, basically. So the evaluation is critical to the professionalization, to your professionalization. It's critical to you as a professional to be able to do a solid evaluation. And having a framework allows you to think about what it is you're examining and why you're examining it. Like, what are the chief major goals of this examination that you're doing? Every time you do an examination, there's a reason to do it. It's not just to do something because I should do something. It's I should do something because I'm going to do this for this particular reason. I'm trying to find out X, Y, or Z. And the evaluative framework sort of gives you that X, Y, and Z. So you're already familiar with the underlying concepts of causation, adaptation, systems, and complexity. So you're already familiar with causation. I know that. Adaptation, you've gotten quite a lot about that, and but I just want to put them out there because I will refer back to them here and there. Systems and complexity will become more apparent as we start looking at these other major concepts that are particular to patient-client management 3, which, and really, you've started to learn about these pathoanatomical conditions all the way back in physiology when you were learning about the inflammatory process. And in musculoskeletal conditions, you learned more about those. And you learned about some etiological factors of pathoanatomy in anatomy and in patient client management too. So, and that's where we start talking about kinesiopathology. So I think one of the underlying, so pathoanatomy and kinesiopathology are two concepts that you have to have in mind whenever you're approaching a musculoskeletal an evaluation that is highly likely or suspected to be of musculoskeletal origin or orthopedics. So the pathoanatomy is what's wrong with the anatomy, if there is anything wrong, and there doesn't have to be something wrong in a macroscopic way. It could be microscopic. It might be out of the realm of sense of capability to detect. It may be tissue that is so close with other tissue that it's impossible to distinguish, at least clinically. Some of these are even challenging to distinguish with imaging. So there are very clear-cut pathoanatomical conditions, like a fracture is a very clear-cut pathoanatomy. There can be pathoanatomy. There can be very clear-cut. There can be abscesses and very clear-cut inflammation, very clear-cut fibrotic changes, very clear-cut arthritic changes, very clear-cut tears. So a tear to a ligament or a tear to a meniscus or tear to a cartilage. These are all very clear-cut pathoanatomy. I think the point to say about pathoanatomy is that the universe of pathoanatomy is gigantic. Every single thing you learned in anatomy could be inflamed. Could be inflamed, it could be injured, it could be infarcted, it could be torn. So if you think about all the different things that can go wrong with tissue or cells, and you apply that to every single tissue that you learned in anatomy, then there's a huge number of possible pathoanatomical conditions. And what we tend to focus on are those that kind of bubble up and show up, have a prevalence that's worthy of consideration. And I will occasionally throw out an example of my wife who had ended up having what's called a plantar plate tear on her second and third metatarsal phalangeal joint of her foot. And it's a very rare condition. It's a very rare pathoanatomy. This is not a ligament that tends to tear. It's a part of the capsule, actually. It's a thickened part of the capsule, which is a ligament. But it's so thick, they call it a plate as opposed to a ligament. And because it's so rare, it took over a year for anyone to even think of it as a possibility. And it was never brought up as a possibility. There was an investigative MRI that was done. So often I feel guilty for having not thought of it, but it had never even entered the realm of possible because it is an anatomical structure that doesn't tend to get torn. And so that's what I mean by anything can happen, but we tend to focus on those things that are more likely to happen. Kinesiopathology are movement system impairments or movement impairment syndromes. There are probably a dozen other names for the fact that someone isn't moving the way they would move. So the reason posture is a big issue is because if someone is in the wrong posture, then they are starting all movements from the wrong starting position. There's a lot of philosophical debate that could go into that, but asymmetries, the FMS is an attempt to understand possible kinesiopathologies. Kinesiopathologies emerge beyond the anatomical tissue, and they go to motor control and biomechanics. So when we talk about the Q angle as a risk factor for patellofemoral problems, we're talking about the Q angle as being either a structural or a functional deviation that is a kinesiopathology that leads to risk of pathoanatomy. So this is a slight modification of the pathophys model you're using in pathophys 2, and I think you use in pathophys 1. and we will hopefully start also using in musculoskeletal conditions. But it's added in, what I've done here is I've added kinesiopathology at where etiological factors used to be. And I've added etiological factors outside, because so etiological factors are typically considered to be outside of the human, whereas kinesiopathology is inside the human. It has to do with the human. Now, more could be probably done here about whether or not certain environments encourage certain kinesiopathologies. And that's where the etiological factors come in. So whether it be the field, the conditions of the field might alter the way people move on that field. The conditions of work are a big one. So ergonomic factors are have a big influence over how people move, and then how people move might lead to pathogenesis. Now, there can be other factors that lead into pathogenesis. It doesn't have to be kinesiopathology. So in looking at this, I probably need to have an arrow between etiological factors and pathogenesis. You could have perfectly normal shoulder mechanics, but due to the sheer frequency and load of repetition, you develop tendonitis of a rotator cuff. There's nothing that forces a kinesiopathological process to be present for a pathogenesis or pathoanatomical problem. But they are highly likely, and physical therapists spend a lot of time trying to figure out whether they do exist. Because if they do exist, this is one of the places we should be intervening. And if they exist as an effect of an etiological factor, like an ergonomic situation, then we need to be addressing those factors as well. So the other difference between this and what you're already familiar with is I've tried to make it a little bit, I've added exacerbating factors, and I've tried to make them slightly separate from risk factors. Risk factors basically are causes of etiological factors or causes of kinesiopathologies or of pathogenesis, whereas exacerbating factors can, here they kind of overlap. They both are causes of pathogenesis, and they're also potential, but exacerbating factors can directly exacerbate pathoanatomy. So, for example, an exacerbating factor could be diabetes or smoking. Smoking is a risk factor for developing certain pathogeneses, but it could be an exacerbating factor for an inflammatory condition. So the overall classification that I'm currently working on to try to make things, try to be helpful, starts with whether the person who is referred to you has a diagnostic classification or not of a treatable problem. And from there, and I'm not going to spend much time on this whole thing here. I'm going to go to the next slide, which is actually just the top part, so it might be a little bit easier for you to see. But the first question is how is this person coming to you? What are their chief complaints? And are they walking in and seeing you with, I have this problem, or are they walking in saying to you, I have this diagnosis? And if they're saying I have this diagnosis, then there's a confirmation process for that to confirm whether they have, in fact, what they're saying they have. And if they're coming in and saying, I have a problem, I have this pain, I can't do this activity, whatever it is, they might just be saying that isn't necessarily diagnostic, and this includes a referral for pain, then you enter into a differential diagnosis process. So let's take a look at the top. If they have a diagnostic classification treatable problem, then you enter a confirmation process. If it's confirmed, then you question whether it's part of your scope of practice. And if it is part of your scope of practice, then you go into what's called a staging process. If it's not part of your scope of practice, then you go to the referral process. And if it lacks confirmation, then you enter the differential diagnosis process. And when we go into the confirmation process, it tells a little bit about what that might look like. From the differential diagnosis process, you decide whether you can discern a differential diagnosis of a pathoanatomy or whether you can't. And so if you can discern it, then if it's discernible, then is it in the scope of practice? If it's not discernible, question mark. At this stage, what do we do? What are we treating? You may refer back and say, we really don't know what to do here, or you may enter a staging process and try to stage completely based on signs and symptoms or symptoms. So the staging process is a process of determining whether someone is in stage 1, 2, or 3. Stage 1 is very clearly acute. Stage 3 is very clearly, I guess you could say, chronic, or there's nothing right now that we're worried about in terms of protection. And there are very little concerns regarding exacerbating the situation with an intervention. I mean, you can, but it's less concerning. It's less concerning that you would make things worse. Stage 2 is sort of in between stage 1 and stage 3. And I'll talk more about those stages when we go into the staging process itself. If someone is in stage 2, or if they're in stage 2, you could consider, and if they're in stage 3, you will and go into what's called the investigation process. The investigation process is where you're explaining possible etiologies, risk factors, exacerbating factors. It's really more of the kinesiopathological process. So this needs some work, because I think the stage 1 needs a bit of this as well, because if part of protection would be removing any exacerbating factors and risk factors. So yeah, this definitely needs a little bit of work. The point here, I suppose, is that in the overall process, there are really 2 different things happening, or I guess you could say 3. There's a determination of the pathoanatomy and what that means in terms of stage, but then there's also this determination of kinesiopathology. What are the underlying, or what are the movement issues that are leading to this problem? And keeping those separate really helps to break down what you're doing in your examination. What are you examining? Are you examining the possibility of a pathoanatomy, or are you examining the contributions to that pathoanatomy through a kinesiopathology, a movement impairment? The confirmation process, essentially, you're asking whether or not there's a diagnostic classification that was confirmed with high positive likelihood testing. And if it was, then you might consider differential diagnoses and rule out with a low negative testing. And if that low negative likelihood testing is negative, then you've confirmed the initial diagnosis, the initial pathoanatomical classification. If it's positive, then you would consider performing high positive likelihood testing to help rule in, and you would essentially continue to add any of these to your diagnostic classification and confirm. Now, there's definitely debate within the physical therapy community about how important this process would be, and whether or not you could essentially skip past this and jump right to treating symptoms and staging. But I think it's important to at least consider differential diagnoses in the confirmation process. So if they did not have this performed, then you would perform, if possible, some high positive likelihood testing, some rule-in tests. If they test positive, then you're considering differential diagnoses. And if they're negative, then you perform, if the high positive likelihood testing is negative, you would then perform low negative likelihood testing to rule out. And if they tested negative on the low negative likelihood ratio testing, then it lacks confirmation. If it is positive, then you go to the staging process. So here's our differential diagnosis process. Basically, there's this sort of loop between the chief complaint and the history and possible exposures, risks, classifications, causes. You've got all these possibilities, and then you start essentially doing low negative likelihood testing. And if it's negative, then these are improbable things. And if everything is over here, if everything is improbable, then it's not discernible. And if but whatever is possible, then whatever is probable, then you enter to what is discernible. So if someone comes in and they had hip pain, then you would consider whether that hip pain is being referred from the spine, and you might do some low negative likelihood ratio testing and rule out the spine and put spinal problems over here. You might put SI joint over here and essentially come out with the fact that you've got some sort of hip pathology as discernible. So let's say they had a negative slump test, put them over here under non-discernible. A negative slump test made spinal problems improbable. A negative SI joint compression distraction, put them over here as well. A negative test for piriformis syndrome, put them over here. But a positive Faber or Fabier puts them over here, and maybe you start seeing what we have discernible is a pathoanatomical issue with the hip. The staging process, if the problem is recent and acute, particularly trauma, then we might immediately go to whether or not we immediately question whether the symptoms are severe or irritable, and if they are, then they're in stage 1. If they're recent and acute, if they're not recent and acute, or if their symptoms are not severe or irritable, then you consider the outcome scores, their function or their disability, lower function LFES, or there are several for the hip, or for other parts of the body, like the Oswestry is pretty popular for the neck. Then if they have low functioning or high disability, then you'd consider them stage 2. Whereas if they don't have low function or high disability, then you would consider the use of the segment during function. So are they able to use whatever body part is in fact a problem for them? And if they're not able to use it because of signs or symptoms, like this was when we sort of start to think of something called a concordant sign. Sort of every time I flex my hip, it really hurts. So I don't flex my hip. I avoid that function. Then now you're looking at stage 2. If they're able to use their hip, then you're looking at stage 3. So the investigative process is probably the least clear defined here. So you're essentially looping through possible kinesiopathological classifications. Some of them are pretty clear cut. Some of them are very well understood at this point. So hip adduction and internal rotation with knee valgus during step down or landing from a jump is very highly associated with certain knee pathologies, and arises from a lack of motor control at the hip. So this would be a clear-cut kinesiopathology that you would consider. But in enumerating the possibilities, you're basically going through an assessment of posture, alignment, mobility, stability, motor control, balance, gait, and functional movement, which I know you've had quite a lot about this. But I wanted to sort of put it within the context that when you're doing all of that, that's the part of the process of looking for the kinesiopathology. It's why do they have the problem that they're here with? And if they're coming to you in stage 3, then it really is the primary point. The primary point of your evaluation is to understand the kinesiopathology. If they're coming in stage 1 or stage 2, now you're thinking about the possibility of needing some protection, some bracing, some splinting, some major alterations to activity in their environment so that they can protect, some inflammatory, recommend, how to handle inflammation, handle edema, to sort of get them through this early acute, irritated, some people say angry, portion of their condition. So staging, once you understand the stage, it really sort of helps figure out what you're going to do. So stage 1, managing symptoms and inflammation and reducing stress and strain, avoiding secondary complications, and these are a lot of the things that you do. Stage 2, same idea, as needed, and you reduce stress and strain as needed. Stage 3, you really, now this is when you're full force into addressing movement coordination impairment, movement faults. So yeah, that's what I forgot to mention. So this idea of kinesiopathology has been around for a while. Sarman was actually talking about it back in the late 80s, I believe, early 90s. Physio-U, when you go into Physio-U, there's a movement faults portion of many of the diagnoses or many of the conditions with which it provides explanations for. And the APTA clinical practice guidelines, some of them start right off the bat with movement coordination impairments. So anytime you're starting with a movement coordination impairment, or in Physio-U, movement faults, I think Sarman talks about these as the movement system syndromes, movement impairments. She kind of goes back and forth a few different times on those. So that's all I wanted to say about this. You will potentially find these to be slightly overwhelming, but also maybe helpful if you take the time to go through them. And by these, I'm going to share my screen again. The pathoanatomical possibilities. So let me talk you through one of these. So for the hip, the pathoanatomical possibilities. And I tried to be consistent with this, so please let me know if I wasn't, because I can make changes to them. If the test is shaded in green, then it means that it really is good for ruling in and for ruling out based on data I was able to find about the likelihood ratios. So this first number is the positive likelihood ratio / negative likelihood ratio. If there isn't a good value, or it's sort of hard to determine what the negative value is, then I've left it blank. So you see the / blank, or some of them might have a blank positive likelihood ratio. I know that there are some coming up later. So if they're in the green, they're good for both ruling in and ruling out. If they're blue, then they're good for ruling in, but they're not so good at ruling out. So 6.1 is pretty good for ruling in, but 0.79 is really bad for ruling out. So a moderate positive likelihood ratio, and a low negative, not a low negative likelihood ratio, or we don't know the negative likelihood ratio. So essentially, hip osteoarthritis, if someone has posterior pain with a squat, decreased range of motion in 3 planes, and hip abduction, active range of motion, groin pain, then there's a higher probability for them to rule in. Nobody's actually put these all together yet and done a clinical prediction rule with all 3, but all 3 of these together are rule in for hip OA findings. So the FADIR is okay. It's good at ruling out. It's good at ruling out hip OA. Click test. Anything that's in the red is good for ruling out. Anything with white is just really not good for either, ruling in or ruling out based on the literature. But I've included them, and I've included the numbers if I could find any But there are people talking about how these should be removed from our approach, even though Faber continues to make it in the clinical practice guidelines. So they continue to recommend this test. I think, yeah, I'm not sure why. So over here, down here, and if there are pathoanatomical conditions that have enough prevalence to kind of show up, either in guidelines or books or just on the top of my head, but they don't actually have any tests for ruling in the pathoanatomy or ruling out the pathoanatomy, then I essentially just put them at the bottom and put the pathoanatomical classifications are ascertained by a combination of history, complaints, physical exam, and ruling out differential diagnoses. I guess that's one of the things to say, is that I honestly believe that most of whether or not you actually know quite a lot from talking to the client and finding out the origins, the exacerbating factors, sort of the concordant signs that when they have pain, and sort of taking a thorough history and really asking a lot of questions is probably going to get you just as far in teasing out what the problems are. But I still recommend you consider first the pathoanatomy, whether it exists, whether you can discern it or not, and then after that, the kinesiopathology. If you jump right into the kinesiopathology, you may miss pathoanatomy, you may miss pathoanatomy or pathological processes that are unrelated, in sort of like a medical screening process. So there's a lot of reasons that we need to do kinesiopathology analysis. We are experts in the movement system, but there's also a lot of reason to sort of tread into that after a thorough evaluation of the pathoanatomical classifications or problems. That's all I'm going to say for now. For those of you that watched it, please let me know whether this was helpful or not.